Of the almost 40,000 new cases of oral cancers in the U.S., 8,000 will die, or 1 person per hour, 24 hours per day. 70% are linked to human papillomavirus or HPV infection. 57% will die in 5 years. $3.2 billion is spent on treatment of oral cancers each year, with an average malpractice litigation cost of $860,000 per case against dentists for the failure of detecting oral cancer. Oral cancer has the worst 5-year survival rate of any cancer, but if it is recognized early, then the chance of a survival is about 90%. To avoid late discovery and improve our patients' health, we now have the most advanced detection system called DOE, or Dental Oral Examination System, to help spot cancer in its early stages, and have implemented an oral cancer screening system into our office. We use a magic violet light and a special goggle as the night vision system to enhance any suspicious areas. This is a painless exam and will take approximately 1 to 2 minutes. Although not every insurance company is covering this procedure, we will make every effort to get the coverage for the procedure. Conventional white light exam is difficult to differentiate abnormal tissue from surrounding normal tissue, since the loss of reflectance in abnormal tissue is quite small, in particular at an early stage. DOE views tissue fluorescence as compared to normal reflectance exam, enhancing contrast of abnormal from normal tissue by more than an order of magnitude. Let's see the physics of this night vision-like fluorescence system. A best analogy is the fluorescence in a jellyfish, originated from green fluorescent protein, GFP, when it glows under a small light by absorbing light 1 wavelength while emitting a higher wavelength. The thicker the epilayer, the weaker the light signal. Violet light from DOE handpiece excites natural fluorophores in both the epithelium and stroma, which resonantly emit or fluoresce at a longer wavelength. The fluorescence is observed through a fluorescence viewer, which transmits green fluorescence wavelength while blocking the violet and noise light, optimizing image contrast. The patent-pending DOE system culminates 10+ years of academic research. While using high-power collimated LED violet beam and high-contrast viewer with both intra and extra oral access capability to reach both anterior and posterior sites of oral cavity with ease. It delivers an optimized image contrast using proprietary wavelength, fluorescence viewer and optics design, while achieving the most operational efficiency and simplicity. Diseases affect natural fluorophores in the tissue, resulting in changes of the fluorescence observed. Here we can see how a dysplasia progresses into an invasive cancer, accompanied by changes in the epithelium. Precancer epithelium lesions typically starts below the surface of a tissue at the basement membrane. It grows and occupies the entire epithelium as it progresses through mild, moderate, and severe dysplasia called carcinoma in situ during pre-malignant stages, and finally breaching the basement membrane into malignant state or invasive squamous cell carcinoma. During the exam, we place light 1 to 4 inches distance from oral mucosa and work in a clockwise order. First, upper labial, then lower labial mucosa. Second, all buccal mucosa, including buccinators and gingiva. Third, tongue, including the dorsal and circumvallate papilla. Gently grab the tongue with gauze or retract with a mouth mirror, and examine the left lateral and then the right lateral borders. Fourth, the floor of the mouth and the ventral surface of the tongue. The anterior sites of the mouth, including tongue and floor of the mouth, are commonly associated with cancers caused by tobacco and alcohol. And finally, palate, including soft, hard, tonsil, uvula, and oropharynx, or back of the throat. These posterior sites of the oral cavity are commonly associated with HPV viruses, or the biggest increase in oral cancer, especially in younger individuals under age 50. Make sure to obtain a thorough medical and dental history, inform the patient of the procedure, and obtain informed consent regardless if they have the screening performed. A non-authorization to do the procedure is as important as an authorization to do the procedure. Perform a thorough head, neck, and intraoral examination visually, as well as by palpating, in particular the lymph nodes. Make sure the patient protective glasses is on. Put on fluorescence viewing filters. Place protective sleeve over handpiece and twist to tighten. Turn the light on by pushing the blue button, and now the light will stay illuminated for 1 minute. Direct and point the light to illuminate the target tissue spot at a distance of 1 to 4 inches, and begin the full oral cavity exam, starting with the labial, in a clockwise rotation. Note that normal tissue will appear green, while abnormal tissue will appear darker compared to the surrounding area. Continue the exam with all buccal mucosa, including buccinators and gingiva. Next is the tongue, which includes the dorsal and circumvallate papilla. Gently grab the tongue with gauze, or retract it with a mouth mirror, and examine the left lateral and then the right lateral borders. Examine the floor of the mouth and the ventral surface of the tongue. Next, examine the plate, hard and soft, moving to the back of the throat, or oropharynx, including but not limited to the uvula and palatine tonsillar area. There are some benign conditions that may appear dark under illumination with the DOE, such as hemangioma, amalgam tattoo, etc. Re-evaluate any suspicious areas under white light, palpating areas using the DOE system again. If determination of the suspicious area is suspect, examine the tissue under the DOE system by blanching and wiping the tissues and observing the response. If the area appears green after this process, then it may be a reactive lesion from an inflammatory response. Remember, the DOE system is a screening tool and not a definitive diagnostic tool. Clinical judgment for each suspicious area should be used in determining the appropriate course of action or treatment. 2-week follow-up may be necessary for inflammatory responses. Document any suspicious areas with a camera by capturing the fluorescence image while the light illuminates the oral cavity, and record on patient's file, remembering to do thorough documentation. For documentation purposes, purchase fluorescence camera filters for your dental camera and thread mount on camera filter assembly. Remember to inform patients of the findings and the next recommended course of action, and refer patient to the appropriate source or perform next course of action. Once consent has been obtained, follow up with patient. For cleaning and disinfecting purposes, you can wipe light with cleaning solution, like a cavi wipe. Do not spray or cold sterilize light unit. Clean the lens by using a Q-tip, slightly dampened with isopropyl alcohol. Now with the dental oral exam system from DentLight, your practice DOEs more. Save lives. Improve patient care. Minimize litigation. Attract new patients.